Dr. Sir, my talk is reconstitution of SFA. So currently, the endovascular treatment of femoral popliteal is a first choice for stenosis and occlusion less than 25 centimeter. So currently, the endovascular treatment for femoral arterial first choice for stenosis occlusion less than 25 centimeter is a recommendation from ESC and European Society for Vascular Surgery. So lower extremity PVD, the clinical presentation may be asymptomatic or intermittent claudication or critical limb ischemia. So what is the indication for SFA CTO revascularization? I'll confirm I talk to CTO SFA. So patients who are likely to benefit from intervention include those with symptoms of lifestyle limiting claudication, one, despite of use of optimum medical therapy and a dedicated exercise program. Evidence of critical limb ischemia with rest pain or non-healing ulcer. So balloon angioplasty effectively dilates the lesion without any residues. A meta-analysis reported that stent placement of femoral occlusive disease does not increase the patency when compared with angioplasty alone at 1 year. A primary stent with self-expanding nitinol stent for treatment of SFA yields a sustained morphological benefit and a trend towards a clinical benefit compared with the balloon angioplasty with optimal stenting. So ESC guideline, long lesion more than 25 centimeter SFA is available if the available autologous vein, then surgical bypass is a class 1 recommendation. Patient fit for surgery may be considered for surgical bypass, it's a class 2A. Now, patient unfit for surgery may be considered for endovascular revascularization, it's a class 2B. So, first of all, it analyzes a target lesion, SFA, classified according to the task 2 classification. Now, another thing is important is SFA procedures associated with prolonged procedure time, more contrast, radiation exposure, and it's the repeated procedures. Now there's a risk stratification development of predictive SFA score. This is a FATO score, and there's a 10-point predictive score if based on the morphology of proximal cap, whether it's tapered, blunt or austere flush occlusion, degree of calcification, length of the occlusion, and collaterals, and number of attempts previous revascularization. If factor score is more than 7 to 10, is a severe complexity, and less than 1 to 3 is mild, and 4 to 6 is moderate. So one is a consideration for strategical that is changing SFA intervention. One is a rapid transition from device to wire-based strategy, one. Second is wire escalation technique and timely alternative site conversion is very important in this case, and less radiation contrast and experience of the operator. So what is the algorithm of SFA revascularization? First is, if possible, is anti-grade wire or device-based strategy. If it fails, wire catheter-based subintimal crossing. If it is not possible, subintimal. And if it fails, and device a wire re-entry using the device. Then if that also fails, you can use the retrograde TBAPDL or transcollateral retrograde based on wire device strategy. You can cross adhesion snare and you can complete the reverse and procedures. And if it fails, re-enter, you can use the cart reverse cart safari technique, again snare and reverse. And if it fails, direct SFA puncture. And what are the device-based crossing? A lot of devices, re-entry devices, or you can use the device to enter the subintimal regions. And anti-gate reconalization. One is a crossover anti-gate or ipsilateral anti-gate approach. This may be intraluminal or subintimal. Let me present a case of a young male, diabetic, a smoker, old inferior wall, post-PTCA, RCA OM, 4 years ago, mildly impaired relief function, severe claudication, left lower limb, and on optimum medical treatment. RTA Doppler done, showed total occluded proximal LSFA, and 70% was a mid and distal. And this is an angiogram. A selective angio showed that it's a stump occlusion, the site of SFA, and 6 friends is used here. And this is a DSA showing this proximal site lesion, critical, and You can see that this distal part is filled through the profunda femoris. And this is a still image. You can see the OC SFA occlusion, and this SFA reconstructed by profunda collaterals, and use the taken right guiding catheter, 6 French, and over the Balkan sheath, and use the thermo wire, 3-5 wire, and but most of the time is going. I hope I am in the same case. Anyway, J loop in the subintimal in the thermo. Then a dual lumen catheter and CFA, and use the Gaia third and J-tip and thermo subintimal. And Gaia third, you can see that the distal cap ends Gaia, but not able to cross this portion. Now again, you can see the distal end of the stump, Gaia not able to cross. So use the J loop across the distal end, able to cross the lesion. Now use the balloon, that is 5x10 Oceanus balloon and Mustak balloon, and we stented with the 5x200 reduction stents. And these are the results. And there's a distal good runoff also. Now it's an elderly male, post of CABG, diabetic hypertension, claudication per right lower limb, and severe claudication on optimum medical therapy, artery Doppler done, total occluded proximal right SFA. You can see the proximal stump here, and it's again the fresh occlusion, and then no stump here is seen, and there's a branching, and there's a distal stump, and the calcification in between. So use the EBU 6 French or the Balkan sheath, and use the microcatheter Rubicon and thermo J-tip used here to cross the lesion. You can see the thermo with the micro tip catheter Rubicon, and this knuckle and subintimal crossing. There's a calcification here, but we are able to enter the lesion just before the popliteal and the distal SFA. And the selective injection to the Rubicon, you can see this femoral artery here, I mean popliteal artery here. And the Rubicon wire, and we exchange the Rubicon with the extra strip wire to that. And the angio, and the balloon with the oceanic balloon, a vascular. And we used then again stent here, 5x200 in reduction, nitinol sulfate stent here. You can see it. And post-stent we are dilated with the 6x100 balloon, and this is a post-stent angiogram. And no restenosis with a good distal runoff. Can see even the distal leg arteries also with good runoff. Third case is a case of old infant function, post-PCI, diabetic hypertensive, mild limited LV and renal function, chronic non-healing also left leg with the severe claudication, artery Doppler followed by total proximal seen LSFA, CT angio showed total occlusion, the left SFA, and angio is around 55 mm. Lesion. Here you can see the still film. One is the stump, and the distal stump is filling through the collateral, and you can see the severe calcification here and at the side in between, and is a blunt stump. And we used support wire and Gaia second here, and not able to cross with the Gaia second, and Gaia third with tip load of 4.5 with support catheter. And still not able to cross this portion, distal portion where there is a heavy calcium. This is a difficulty I had in this case. Now I have to use with the approach guide wire, where the tip load is 18. And you can see that after we are tried with the coronary balloon, not able to crack the lesion here at the focal site. Then again, I used a stress tip wire, exchange with a stress tip wire and 480 oceanus balloon. Still, you can see the distal part not able to crack, but subsequent with the higher pressure balloon dilatation, able to do it, and then we stented with the EV3 stent, that is Everplex Netinol surface penis tank, dilate with the Mustang 600 balloon. And this is the result. Distal runoff and site of the lesion. Significant resolution stenosis, and you can see the good distal flow in the leg arteries. So retrograde reconstruction possible if there are two things. One is inadequacy the effluent collateral supplying blood to the distal ischemic area. Second, you should have presence of good distal runoff with respect to good patency once you do the procedures CT after reconstruction. If these two criteria is there, then only to attempt the retrograde reconstruction, either transcollateral intraarterial or transpedal strategy. And patient should be in supine position, 60-degree external rotation, angiogram into the proximal site and the puncture site 10 centimeter below the distal situate lesion using the micro puncture needle and my catheter guide wire is 0.18 or 14 with a small sheath for French. And distal crossing may be the controlled CRT technique, or it can be the two catheters under technique or bidirectional balloon angioplasty. And you can snare it once enter this distal proximal part and complete the procedures. So, one most important the symptom only do the SFA intervention in patient symptomatic claudication and go with the task 2 guidelines. Then a morphology of the lesion based on the occlusion length, calcification degree, operative experience, runoff status influence the result of the procedures. The operator needs to be familiar with different reconstruction technique, including antegrade and retrograde technique, indicate application of antegrade and retrograde reconstruction for SFA is effective and safe.
Thank you, Dr. Asokan, for such a nice presentation of and very nice cases. Long stenosis, long occlusions have been treated. So there are a few things I would like to ask you. What do you use drug-eluting balloons in these cases, or stents are the preferred mode of in these patients?
Sir, if it's a short lesion and a non-occlusive case, you use the balloon angioplasty. Previously, using the drug-eluting balloon. And if it's a long lesion and we start to occluded vessel, and we use the third generation Netinol stents. And initially using Supera, and now other stents are available. And what we are worried about the fracture rate and reocclusion restenosis.
Good, thank you.
Dr. Asokan, one question. I think a very good approach also is a popliteal approach. Tibial is good, yes, but I would prefer that in some cases popliteal approach, because with popliteal approach you can recognize 99% of the cases.
Yeah. Yes, sir. Agreed, sir.
And you can place any stent you want. You can use recruiting balloon, anything. It's not infused.
Okay, sir. What should be the position, sir? Position of the patient, which position you do it usually? Popliteal.
The prone position, or which position do you take? Dr. Henry?
Excuse me, difficult to hear you.
Discussing about the position of the patient while doing popliteal.
Prone position.
Prone position. Yeah. Okay.
Yes.
Yeah.
But
initially,
also,
take
in
the
a
patient
simple position, you can puncture. In any position, you can puncture. And you can use 7 French sheet in a popliteal artery.
7 French
And
sheet,
the
yes.
risk, yeah, 7 French. Even 8, it depends on the diameter of the artery, but 7, 8 French sheet you can use without any problem.
And then when you take out the sheath, how do you compress it?
You just with finger, it's not a problem. The unique complication we may have is some arteriovenous fistula, but very, very limited in maybe 3-4% of the cases. But it doesn't matter, and I have never done anything for this arteriovenous fistula. That's a unique complication. I have never seen thrombosis, large hematoma, never. I have done maybe 300, 400 cases, and believe me, it's a very safe technique.
So compressibility is good in the popliteal position?
Yes. You
So,
compress.
popliteal, do you go for intra-arterial occlusion before sheath removal? Do you recommend intra-arterial occlusion with balloon occlusion before removing the sheath?
Excuse me, I can't hear you.
My question is, before removing the popliteal sheath,
Yes.
do you recommend intra-arterial, that is proximal balloon dilatation?
No, you remove your sheath and you compress with your fingers. That's all.
Compress it.
Okay. Oh yes. For 5, 10 minutes, like a femoral artery, but the risk of hematoma or complication is very, very limited. Less than with femoral puncture. No, tibial puncture is good, it's not a problem, but it's more complicated than puncture popliteal artery. A puncture of popliteal artery, it's very, very simple. We inject contrast through the femoral artery, and you can see where is the popliteal artery, and you puncture under fluoro, and it's very simple.
Thank you, Dr. Asokan.
Yeah, thanks.
Excellent presentation.